Thank you, Dr. Hilda. Now I invite Dr. Sujith sir, cataract, cornea and refractive surgeon, senior consultant, Trinity Eye Hospital and Astra MIMS, to discuss a technique that represents the pinnacle of the selective endothelial replacement DMEK. Over to you, sir.
Very good evening. Thank you, Dr. Ashwati, for including me in this IC. In continuity to what Dr. Hilda spoke about the endothelial keratoplasty, mainly DSEK, the other two endothelial keratoplasty that is being practiced nowadays is ultra-thin DSEK and DMEK. We'll be talking about DMEK in this talk. It's basically a game of microns. All these three have different thickness of grafts. Like in DSEK, you may have it around 140, 130 microns, roughly the size of a LASIK flap. If it is an ultra-thin DSEK, it will be around 90 microns, roughly the size of a femto LASIK flap. And if it comes to DMEK, it's just one layer of 15 microns, roughly 1/3 of the epithelial thickness. So when we look at the statistics, we always depend upon the US statistics. And as per the US statistics, for the last 2 decades, the DMEK was climbing up the ladder. Endothelial keratoplasty was climbing up the ladder, and DMEK over the last few years. Now the 2024 statistics clearly says that DMEK has become the most common keratoplasty procedure done in US domestically. So why do we do more of DMEK, or why DMEK is preferred? Is it because it's technically more easy, or is it the learning curve shorter, or is it because we don't need any special instruments, or it's just an extension of DSEK? Basically, no. There was one study in which an experienced DSEK surgeon studied his 200 cases, the first 100 cases, DMEK surgeon, first 100 cases and the later 100 cases. And he compared the results and the complications. And it was clearly noted that the first few cases or first 100 cases had more of complications, and the results were not as good as in the later cases. So the DMEK is preferred not because it is easy to do, because of its better visual impact on the patient. It's minimally invasive, faster visual recovery. There is minimal refractive shift during the after the surgery. There is less failure, less risk of rejection, and better utilization of the donor tissue. I saw one video in which Dr. Sanjana was peeling away a good endothelium for her DMEK, for her DALK, that could have been used for another patient. So same donor can actually be utilized for 2 patients. So it's all impact of the lesser graft thickness that is giving all this advantage for DMEK. In comparison with DMEK and DSEK, it is shown that the endothelial cell loss is comparable for both the procedure over the years. But the result, the BCVA is much better in DMEK compared to the DSEK. The DMEK surgical steps are entirely different from that of the DSEK, and in short, we will be going through each of these procedures. So the first is case selection. Ideally, any endothelial disorder can have a DMEK, but a good candidate for a beginner, or as we told, initial few cases would be a clear-cut Fuchs endothelial dystrophy with or without cataract, or post-cataract decompensation, or a failed DSEK. And other cases like ICE, PPMD and all may be taken up as you gain more experience. It should not be taken for surgery, for DMEK surgery, when you have a stromal scarring, because the visualization of the details in the anterior segment is very important in DMEK, and if you can't make out those details, it will be very difficult to do the surgery. Again, very hypotonous eye, FAK, if there is loss of posterior support, either by IOL or an iris support is not there, if there is already done a glaucoma surgery where the air management may be difficult. So all these things make the DMEK surgery difficult, though the experts are doing it with different different modified methods, but still it is not an ideal case for early cases of DMEK. Donor selection: an optical quality eye with a good count more than 2,300, a phakic eye. 2 important things while selecting donors for the DMEK is the age group of between 50 to 70. The younger the age, the scroll is so tight, it is very difficult to unscroll inside the eye. It's a very elastic DM. Above 70, of course, the risk of more, we are manipulating directly the endothelial cells, so there is more risk of endothelial cell loss. And specifically, you look for non-diabetic eyes, because it has been shown in studies that in diabetic eyes there is adhesion between the DM and the posterior stromal layers, which makes the DM stripping, donor preparation a little difficult in those cases with diabetes mellitus in the donor. The donor preparation is one critical step in DMEK, which needs to be expertised while you are studying, learning DMEK. You can have three options. You can have a manual preparation of the DMEK if you are confident. Now the eye banks are giving you prepared, pre-stripped tissues, and now US are having pre-stripped, pre-stamped, pre-loaded tissues. You just need to inject and put an air bubble. So as far as we are concerned, I think the best thing is to learn the manual preparation. And the manual preparation studies have shown that if you follow a same method, the reproducibility of donor preparation is very good, up to 98%. The DM stripping in the recipient is one step. This is for a DSEK, which I am showing, because two steps are different from what you are doing in the DSEK. In DSEK, we normally do it in a dilated pupil. I saw Dr. Hilda using it with stain. That is one good step. If you are not using stain, you can have a very good visualization of the DM if you are using it under dilated pupil. But in DMEK, we always do it under constricted pupil. And you can do it under visco or using an air bubble. Second important step in donor preparation, the host preparation, is the inferior PI. You can use, because you will be putting a longer and a tighter air tamponade in DMEK. So you need an inferior PI, which can be done preoperatively using a YAG, or during during the surgery before you put in the graft. So coming to the donor preparation, that is one important step of DMEK. So it starts with selecting an ideal donor. You have to stain the donor eye for a longer period. Can you keep the volume low? So after enough staining, you have to bring the dye, but you have to fill it with VSS, and with a blunt tip medicines, you try to initially, okay, I forgot that step. Initially, 9.5 or 10 millimeter trephine is used to make it very partial trephination, so that only the DM is cut. Don't cut into the stroma. And with this Sinski, you are trying to make out that margin and slightly lift the edges of the DM all around through 360 degree. So once that is done, you use special forceps and try to peel that DM very carefully. You should not pull it vertically. You have to, your hand movement should be like very horizontally along the horizontal axis. You have to pull it, and you will not pull it all along. You will not completely detach it. You will pull it up to 3/4 and keep a fold there. And once it is reached, you can, next thing is to mark or stamp the graft. So for stamping the graft, you can use two methods. One is like, at this stage, you can keep it like this and put in an air bubble between the two folds, and with the air bubble supporting the under the fold, you can put a S mark or F mark, asymmetrical alphabet. That's all. Put over the upper fold. We have time, right? And unfold it and take the graft. In another method is using a punch. After the 3/4 of give a 2.5 mm punch, cut it, and then go to the other side of the graft, open up the punch area, and stamp it from, after drying up, stamp it from the other side. So once you have made this 9.5 or 10 mm graft, then you can put it back and use the actual size which we need, and 8.5 or 8, whatever is the desired size for that particular, refined size for that particular case, and then strip that. strip, that DM. So once that this is the donor scroll configuration that we expect to get. That's called the double scroll configuration, where you must understand that the endothelial side is in the exposed part. So that is very important. The endothelial side is in the exposed part, and this configuration can be of various type. Before going to that, the marking is very important, because you can have three types of marking, either by this S stamp or an F stamp, or you can make a peripheral notch in two different directions, which will be like a half of an arrow mark, which shows that it's either clockwise. You have to look at whether it's in the clockwise or an anti-clockwise. And the third method is to put a 1 and 2 marks, again asymmetrically, so that just like you put it in the LASIK flaps, so that you see whether it's turned or not. And loading the scroll is also, this is a video I borrowed from Dr. Fogler. I normally use this. You can even use an IOL injector also. I normally use this glass injector, which is having a wider bore on one side and a thinner bore on the other side. You take in the graft through the wider one, and once the graft is inside, and you push it and pull it to get the correct orientation, and once it is in the right orientation, you switch the sides and connect it to the injector and push it into the eye. Donor insertion, again, it's also different from what we used to do in the DSEK. Here also you need an increased AC. Momentarily during that period, the IOP should be high, but once immediately the graft is inside, you have to lower the IOP. There is a high risk of graft expulsion when you take the syringe out, so you need to immediately cover the graft and the wound and suture it. So the graft insertion, again, this is I borrowed from Dr. Fogler. So important steps are: insert the scroll, identify the correct orientation, position it in almost perpendicular to your wound. Then you shallow the AC so that it stays there. Then you secure the wound. Then try unscrolling by tapping method. So coming to the different unscrolling techniques, you have to learn about the various scrolls that can be available, and this is like various types are there: double scroll, single scroll, simple folds, origami, bokeh. Different types have been explained, and this is a very good site for you to look for, like how each scroll is. There are specific techniques also for unscrolling each particular scroll. The main techniques in unscrolling is with the tapping with a single cannula, or that's the standard technique, or air bubble rolling, or two parallel cannulas, single sliding cannulas, or a combined technique. So actually, I wanted this video. Yeah. So this is the tapping technique. The main principle here is you are unscrolling it with the help of the water currents that is produced by the tapping. So wherever there are folds, you tap above that or just beside that, so that the water current that is happening inside is helping in the unfolding. Again, the air bubble is used to do the same. And the other method is by using the sliding of the cannulas, like the sliding, slowly sliding. For all this, you keep the AC very shallow, you slide it, you rub it against the supporting iris and slowly unscroll it. It can be used with single cannula or using double cannulas to both sides. Whenever there is an unfolded side, when you do a paracentesis on that side, the fluid gushes out, and with that it gets unfolded. So it's by repeatedly performing this only we can master this. Apart from donor preparation, this is one technique, that is one step of DMEK that is a bit worrisome for the beginners. So post-op, the results are excellent even on day one. You can see a very clear cornea. We won't see any margins between the donor and the recipient. After 2 weeks, like it's almost like a pristine clear cornea, where you can't even make out whether this eye has undergone a corneal transplantation. Comparison with the other corneal transplants or the DSEK, it is, as I already told, the ECD decline is almost the same. But the comparing all the other indications like endothelial cell loss, mean vision, mean CDVA, graft detachment, graft failure, it has been clearly shown that DMEK is much better in comparison with the ultra thin DSEK and DSEK. especially the primary graft failure and rejection rates are much less compared to the other methods of endothelial keratoplasty. And as we already discussed, the perceived difficulties or barrier to uptake or upgrade to DMEK is mainly in two areas. One is in the tissue preparation and other is in the tissue insertion. Thank you.
Thank you, sir, for the wonderful talk.